Hello. I wanted to share some experiences that I've had in my journey as a physician. I recently started working at a community hospital, but primarily, I think, most of my time, that is surrounded by a number of different nursing facilities and sort of old folks' homes, if you want to call it that. So we have a fairly high geriatric population. And subsequently, a number of patients will come in on a daily basis with acute decompensated heart failure in one flavor or another. And there was a recent case that brought in that the management of it seemed a little bit foreign to a lot of folks, not only to the EMS crew that brought the patient in, but also to the more junior doctors around and to some of the nursing staff. And so I wanted to talk about this because I kind of forget sometimes that not everybody has had this broken down in a way that's fairly easy to sort of recognize. We think of heart failure as this sort of broad thing, but realistically, heart failure is not really one broad thing with this difficult to remember algorithm behind it. It's really a bunch of kind of smaller, 5 or 6 different little smaller entities that all have their own little individual treatments. Now, we have to be careful with this because if you prescribe the wrong treatment for the wrong type of heart failure, even if it's heart failure, you can do somebody a lot of damage. So heart failure itself, heart failure again is not one distinct entity. It's more of a syndrome that's got a lot of littler entities swirling around it, 5 or 6 phenotypes of heart failure, maybe even more than that, each that have their own pathogenesis and their own pathophysiology, and each react a little bit differently to different treatments, and we should treat each one a little bit different. So you can't say that heart failure, who's got heart failure? Well, they're going to be swollen and they're going to have pulmonary edema and they can't lay down, and it's big old diabetic men. Who've had heart attacks in the past. That's not really the heart failure kind of picture. That's one particular picture of heart failure, but it's not the heart failure picture. Not everybody looks like the Michelin Man. They may have swelling or they may not have any swelling, or they may have pulmonary edema and no swelling at all, or they may have swelling and no pulmonary edema, or they may just be purple or cyanotic. And being able to distinguish that is going to be important to figure out how to treat these folks, because again, not all heart failure treatments, air quotes, are the same and don't work the same way for different people, depending on their heart failure syndrome. So one thing that we need to get out of the way first is that when you think of heart failure, whenever somebody says heart and problem, most of us think of the person clutching their chest and saying they've got this elephant on their chest. Keep in mind that that is, ACS, that's cardiac ischemia, that's that kind of thing. Now, the person may be in frank shock, and there's other ways they can do it, but primarily what you're going to see with these folks, the thing that's going to bring them in or make them call 911 is that they can't breathe. It looks like a lung problem. It looks like a respiratory problem rather than a heart problem. But in pretty much anybody who is either old and has diabetes or is old and has some other comorbidity, you have to think dyspnea, heart failure. Dyspnea, heart failure, dyspnea, heart failure in the elderly population, or in folks who have other risk factors for it, such as, in pregnancy or something like that. And a lot of the time you'll be right, some of the time you won't be, but you got to be thinking about it because, again, the treatments are somewhat specific depending on what phenotype of heart failure or what their particular flavor of heart failure is. So the good thing about this slide, it is super busy. I realize there's a lot of stuff on it, but this tells you everything that you need to know about treating heart failure for the most part. Nothing can cover everything, but this is pretty good. It gives you all the different phenotypes and the ways that we can treat each of those different phenotypes, and we will hit each one of those individually in just a few minutes. The good thing about treating heart failure in the pre-hospital environment especially is there's basically 2 goals. You get the person to survive long enough to get them to the hospital and do more, and you improve their symptoms. And the symptom improvement is really the overall goal in things. Nobody really, once you get heart failure, nobody really expects that we're going to, outside of doing a heart transplant or something like that, that folks are going to be, we're going to fix this. This is going to all completely go away. It's how do you improve symptoms for the most part. And same thing, how do we decide when somebody in the emergency department is okay to go home from their heart failure picture? Well, it's is their oxygenation okay? Do they feel okay? Are their symptoms improved? How do we decide when enough nitroglycerine's been administered? Well, are the symptoms better? No? Okay, give more. And that's fairly straightforward, and that's kind of nice. And then again, the first goal, keep them alive. Once you do those 2 things, you've treated heart failure. So the treatments for heart failure, the primary heart failure treatment, again, we're going to be treating dyspnea most of the time. Our primary treatment for dyspnea in acute decompensated heart failure is going to be non-invasive positive pressure ventilation, CPAP or BiPAP, depending on what your system has. We've talked about this before on EMS grand rounds, but to give you just an idea, what is CPAP essentially? CPAP is positive pressure that is applied constantly throughout the respiratory cycle. So you set your device to 7.5 centimeters of water, it should be delivering 7.5 centimeters of water of pressure between the mask and whatever is resisting the mask. Either it's the glottis, or it's the face, or it's the lower airways. Underneath that mask, you should get, when everything is in steady state, about 7.5 centimeters of water, theoretically. Now, some things to sort of bring up. How does that actually happen? Well, if you look at this device, what it basically is a constant flow of oxygen attached to a tight-fitting mask that gives you a seal, and then that system's got a PEEP valve on it. And that's basically the way that CPAP works. It just pumps oxygen until it reaches that 7.5 or whatever you've set the thing at on the valve, and then the rest of the oxygen runs out after that, or the gas I should say runs out after that. It's not 100% oxygen. Things to bear in mind with your system. Number one, if you have a low flow system, what you are essentially going to be doing is sacrificing pressure for flow. So you may decide, oh, I need lots of pressure on this person, and so you turn the device on and like dial it all the way up. One of the problems with it is, though, you've only got a fixed flow of gas, and if you trade pressure, you have to decrease essentially the amount of gas that the patient gets. So there's some ways that you can kind of fix that. You could increase the maybe increase the flow rate of the device itself if it's flow generated essentially, or sometimes if you decrease the pressure, they're able to entrain more air a little bit faster. So those are potential thoughts if you have somebody that doesn't tolerate the mask very well. BiPAP is basically similar to CPAP, except that when the device that is generating pressure, when it senses the patient takes a breath in, then it pushes some extra pressure. So if your PEEP is essentially set at 5 at that point, which the device will constantly deliver, when it senses that you take a breath in, then it will push with whatever you've set the top number at, your inspiratory pressure. So 12, 15, whatever it is, the device gives you a little bit of kick there. That's good in that it can help you, give you a little support when you try to breathe in, and then the pressure itself acts like PEEP in that it distends your alveoli and keeps them open. Real quick, what happens physiologically when you apply constant pressure to the patient's airways? Basically, you transmit that pressure all the way down to the alveoli, down in the lungs themselves, down here. That helps to keep those alveoli open, even when usually if you respire and your alveoli are kind of full of fluid, they'll collapse down like that. Having a little bit of pressure in there will help to keep those little guys open, help to stent them open, and then you don't have to like slam them open each time you take a breath in. So it's easier to get air in. It also increases interthoracic pressure, and a lot of times, we hear about this when they talk about cardiac arrest stuff. It's like, oh, you got to have negative interthoracic pressure. Interthoracic pressure is a bad guy, blah, blah, blah. In heart failure, it's actually a good thing, because it not only decreases preload, which sort of helps improve flow, forward flow, but it also decreases relative afterload in that you have more pressure up in the chest cavity itself. Like you see all those green arrows, when you distend the lungs a little bit, that pressure gets transmitted into the chest cavity itself, and that puts pressure on the aorta, which helps to push blood out underneath the diaphragm. So you push it out down to the legs and improves forward flow. So relatively decrease in afterload compared to the belly, and overall makes it a little bit easier to get blood pumped out of the heart. So not only does it do the respiratory stuff that we like, but also can help to decrease preload and afterload and improves flow in the patient with heart failure, which it can actually be super helpful. So we've talked before about the benefits of using CPAP or BiPAP. Decreases atelectasis, makes the ventilation perfusion mismatch that goes on in your lungs better. Can provide you a little bit of inspiratory support, and helps to theoretically at least move a little bit of fluid across the wall of the alveoli themselves and maybe back into the circulation rather than collecting in the interstitial space. By the way, I've mentioned this before as well. Say you don't have a CPAP or a BiPAP system, but you have somebody that you think would benefit from it who's in significant respiratory distress. You can sort of finagle this thing around. And this takes a lot of effort and is not ideal. But if you had to do it, if you were to take a nasal cannula, put it on the patient, turn it up to 25. And by the way, it'll be fine. The nasal cannula is not going to explode. There's not going to be any problem. I know it's only designed to go up to 6, but it'll be fine. Trust me. Crank the thing all the way up to like 25 liters per minute on the nasal cannula. Take your BVM, crank it up to 25 liters per minute so you get plenty of forward flow. Take a tight-fitting mask, put it on the patient's face with a good seal. That gives you constant flow and a good seal, and then if you attach a PEEP valve to the end of that, that gives you a pressure regulation. So what you've essentially done here is create CPAP, again, PEEP essentially. And if you are assisting the patient's ventilations with it, then you are generating forward flow and essentially BiPAP. So this is a way that you can essentially make a CPAP device if you don't have one available. Again, use the commercially available devices because they're more reliable, but if you had to do it, this would work in a pinch. Let's hit up nitroglycerin real quick. We think about non-invasive positive pressure via inhalation as being the primary treatment for dyspnea. We should also think about nitroglycerin as being a primary treatment for dyspnea. Nitro is about one of the cheapest, most effective things we can do for our heart failure patients, but one of the ones we use pretty infrequently. Because what do we think of nitro for? We think of nitro for chest pain. I've got crushing chest pain, I take a nitro and then I feel better. Nitroglycerin, it works really well as a vasodilator in acute decompensated heart failure, makes people feel better really fast. Now, how do you give this thing? Well, you can give it as nitro tabs. The 0.4 milligram tab is about 40% bioavailable, so just under 50% or so. If you give 3 tabs in 15 minutes, then that works out to somewhere around like 400 mics total, thereabouts. And so it works out somewhere around like 40 mics per minute is where I'm kind of getting at. So if you think of the actual dose you're giving to somebody with nitro tabs, it's about 40 mics per minute. And that works fairly reliably for the tablets themselves or for the spray. We don't often think in EMS, but sometimes we get tasked with transporting someone on nitroglycerin drip. Now, if we're treating somebody with chest pain and we give them, an IV drip of 5 mics per minute of nitroglycerin, something like that, okay, maybe it relieves their chest pain. If we're dealing with somebody in heart failure, though, we're going to be setting these IV doses at least 50 and going up from there, 50 mics per minute, which again is that dose that you gave with sublingual nitro. 2 things to point out there. Number 1, sublingual nitro, when you administer it, gives you a dose of about 50 mics per minute, and you don't have to start an IV, so consider that strongly in your heart failure patients. And number 2, doses up to 250 micrograms are a pretty standard thing if you have somebody with significant heart failure. In fact, in folks that are severely hypertensive, we should probably not be giving 50 per minute or something like that. There have been studies where they've safely given 1 milligram or 2 milligrams of nitroglycerin essentially as a push. And no untoward effects. Now, it's got to be in the right patient. You wouldn't give that to somebody whose blood pressure is 100 systolic and looks poorly perfused. But in the right phenotype of heart failure, high doses of nitroglycerin are safe. And so we should be using nitroglycerin. We should be up-titering nitroglycerin pretty quickly if that's something that you're able to do if you have it available to you. One other thing to sort of point out why this is important, doses from 5 mics to 250 mics per minute, the lower doses that we're kind of used to giving, do help in heart failure. We sort of think, oh, maybe there's some afterload reduction with that. Under 250 mics per minute, you don't get a lot of afterload reduction. You don't really cause dilation in your arterial side. You cause it mostly in the venous side, which decreases your preload, which gives you less blood to pump out, which decreases the amount of blood that gets stuck in your lungs. And makes you breathe a little bit better. So some vasodilation is useful. If you want arterial dilation, if you want afterload reduction, true afterload reduction, you really have to go with doses above like 250 mics per minute. Well, you can't talk about heart failure treatment without talking about diuretics. Again, from an EMS setting, diuretics probably don't have a place for us. Lasix, furosemide, probably doesn't have a place for what it is that we're trying to do. Because again, what are our goals? We want to get the person feeling better, and we want to get the person alive to the hospital, maybe in a little bit better shape than they're at already, and then kind of figure it out from there, or let somebody else figure it out from there. Keep in mind what diuretics do. So the idea is that you have this extra fluid and it's all out in your tissues and your body overloaded, and so you pee this stuff out, and as you pee this stuff out, your pulmonary edema gets better and your peripheral edema gets better. And that makes a lot of sense in theory, But the problem is that, number one, it can be very hard to figure out who is actually total body overloaded and who's just overloaded because the fluid's in the wrong spot. So you could have terrible peripheral edema and not be body fluid overloaded and not really benefit from diuretics per se. You could have terrible pulmonary edema and not be body fluid overloaded, and giving diuretics really wouldn't be of any benefit to you. So there's a very specific group of people in which it does actually help, but also it takes too long for it to be of use for us. Remember, you've got to actually like activate your kidney and the loop and all that kind of stuff, and then it has to actually, lead to some diuresis. Remember, it has to actually activate your kidney, and I don't remember the exact mechanism, but it has to work through the kidney itself, and then you actually have to pee out a lot of stuff, and that takes anywhere from an hour to 90 minutes to really start having a significant effect. So by that point, the patient is usually in the hospital already and outside of our care. And so in this case, it doesn't really help in some cases. It makes some people worse, and it can be hard to figure out which person that is in the field. So I'm of the mind, leave the diuretics alone. There's not really a place for Lasix in heart failure treatment in the EMS setting for us. All right, so something we don't really cover very often, real inotrope. So most of us have heard, when you go through medic class, you probably have heard of like vasopressors, so norepinephrine, epinephrine, that kind of thing. We've seen those, probably given those. May even have put people on drips if you're like a critical care transport provider or something like that. So when we talk about inotropes, a lot of folks kind of use inotropes interchangeably with vasoconstrictors or vasopressors. Most of the stuff that we are used to giving in the emergency setting is usually a vasopressor. When we're trying to raise somebody's blood pressure, we usually don't give them much that causes inotropy. We give them stuff that causes squeeze of their periphery, like phenylephrine or vasopressin or norepinephrine. Just clamps down your periphery, which does raise your blood pressure. Good for like maybe sepsis. But if the problem is that your heart is just not able to squeeze hard enough, if it's a heart problem, a pump problem, that's not all that helpful. And so in that case, the things we kind of lean on are probably going to be the ones with more inotropy itself, the actual better squeeze. And of those, there's two that are sort of ideal for heart failure exacerbations in the right setting, and that's dobutamine and milrinone. Dobutamine's a beta-1 agonist. It causes just more squeeze and also some vasodilation. Milrinone causes more vasodilation and a little bit less squeeze, but both are very effective. Both work real well in the right setting. And a lot of times this is going to be in sort of end-stage heart failure, the person who's poorly perfused and hypotensive. If you provide some additional squeeze to their heart that way. Sometimes you do have to add on an actual vasoconstrictor to give you just a little bit of vascular tone. So you sort of flog the heart to make it go better with either dobutamine or milrinone, and then you add on a little bit of peripheral squeeze with it, with like norepinephrine, and you can get the patient's blood pressure up and sort of force their heart to work a little bit better. The other thing in the EMS setting is that there are a couple of drugs that you may have hung previously. Dopamine, it has some inotropic effects, although we're getting away from dopamine. And then low doses of epinephrine, like I think it's 5 mics per minute, something like that. Low doses of epinephrine have a little bit more inotropy with less vasoconstriction. If you get into the bigger doses like we tend to give, you're mostly getting vasoconstriction with still some inotropy. But again, the idea, just so that you're familiar with it, you may not actually have these unless you're a critical care provider, but milrinone and dobutamine tend to be the ones that folks get used for strictly heart failure or cardiogenic shock. Those tend to be the good drugs for it. Now, that is the different treatments that we might use. Now we need to talk about how you would actually put those into practice. So who is it that would get each of these drugs? We'll talk about those on the next video. Stay tuned.